82-year-old gentleman was referred to us with a suspected lower bile duct obstruction, secondary to suspected mass in the head of the pancreas on other imaging studies. Patient was also referred to us for definitive staging in view of the mass. And you can see that when scanning from the duodenum, we are seeing multiple large nodes, perilocoidocal, and you see the bile duct in cross section now. Bile duct, the pancreatic duct, bile duct appeared dilated, the pancreatic duct appears prominent, dilated because of the mass. This is a hypoechoic lesion occluding both the ducts, measuring almost 3 cm by 2.5 centimeters. So this lesion is irregular, hypoechoic, huge peripancreatic hypoechoic node, and patient is 82-year-old gentleman and with obvious other comorbidities such as diabetes and ischemic heart disease as well. So in such situation you see echogenic bile, you can see in the bile duct. This heralds cholestasis and secondary infection perhaps. So you can see up to the common hepatic duct bifurcation. When you withdraw the scope, you can see almost up to the CHD there. Now the CHD is coming in the view. We'll gently withdraw the scope, evaluate the mass properly, and you can see the pancreatic duct dilated 6.2 millimeter. Gentle withdrawal of the scope into the stomach. You see the pancreatic duct prominent, dilated pancreatic duct in the body and the tail of pancreas. No metachronous lesion in the pancreatic body or the tail evaluated, as we see the whole pancreatic body from the stomach. Gentle to and fro movements will allow you to see the duct in clarity, and as we withdraw a little further, we see some small peripancreatic nodes. A radial evaluation allows you to have an overall mapping of the gland, detection of lesion, diagnosis of lesion with the help of EUSFNA, and eventual palliation of cholestatic symptoms with ERC and placement of a self-expandable metal stent. So this patient has cholestatic symptoms, total bilirubin almost of 25 milligrams %, with severe cholangitic and cholestatic symptoms. We are still evaluating the celiac artery. There are multiple hypoechoic subcentimeter nodes, and we all know that celiac node in the presence of malignant lesion in the head of the pancreas, we are almost ruling out a curative resection. So subcentimeter hypoechoic nodes, these are the nodes which are missed on all conventional imaging, is our experience, and I'm sure our colleagues in the audience would also agree. So we went ahead with linear echoendoscopy. Now linear also shows the similar kind of anatomy. We can see the mass, we can peripancreatic lymph nodes. So advantage of EUSFNA is that you can go after the nodes, you can go after the primary lesion in the same sedation, unlike CT guided interventions for tissue acquisition. So you have this huge mass which is adherent to all the major vessels. CT also showed the similar findings. So the main idea is to have tissue acquisition and diagnosis followed by palliative metal stent placement for cholestasis. We can target EUS guided FNA transduodenal. We are going ahead. We did color Doppler evaluation to make sure there are no intervening vessels in the needle path, And our technique is slightly modified. We prefer smaller gauge needles here for cytological aspiration. You can see here my needle is staying calmly inside the lesion, and the aspiration is seen happening on the ultrasound when you see the needle being withdrawn very gently. So very gentle withdrawal, and we have aspirated the material. Following this, we are seeing the aorta here, celiac artery takeoff. So this is where we do celiac plexus neurolysis if required, and you can see some irregular hypoechoic structures around the takeoff. You can see the SMA taking off just below the celiac artery, and this is where you can do celiac plexus neurolysis. So patient who requires celiac plexus neurolysis of intractable pain, so you can do EUS guided CPN at the same time. You can see the small lymph node, sub-centimeter lymph node which we saw, and we also need to take an FNA from there, especially when you do not have a cytopathologist standby. So there are patients who where we take a FNA from the node, FNA from the primary lesion. We prefer to take an FNA from the node, preferably first, and then followed by the lesion to prevent using two needles, especially when it's going to impact the staging. So you have a patient, we know that this gentleman who is above 80 years old with so many comorbidities, here we are taking USFNA. You can see how well a sub-centimeter node can be targeted and the tissue can be taken. Both the FNA showed adenocarcinoma and metastatic adenoCA in the node. Now we will proceed with ERCP. We prefer to cannulate with a sphincterotome loaded with a hydrophilic guide wire. As you can see here, we managed to get entry into the bile duct across the obstructive lesion. We push the catheter deeper into the system, and then we inject contrast from the top down. This is our standard practice. You can see a long stricture in the pancreatic head region with a dilated bile duct and IHBR. Once we exchange the guide wire, we prefer to make a biliary sphincterotomy adequate enough for our subsequent interventions. We all know that deeply icteric patients have deranged INR, and therefore we limit our sphincterotomy to a certain extent only to facilitate subsequent intervention. We do not require a biliary sphincterotomy the way we do in stone disease, because here we only need to pass certain. Now here we are dilating the stricture with a 10 French biliary dilator, you can see, because we need to pass a 7 French stent delivery device for deployment of self-expandable uncovered. I prefer uncovered stents for some reason, because we have had a couple of patients with occluded cystic duct secondary to cover stent. So cystic duct insertion sometimes can be difficult to ascertain, especially when patient has cholangitis. We do not want to inject too much of contrast. So here we are going ahead with a self-expandable uncovered 8 centimeter stent. We prefer to keep a little longer stent for a definitive palliation, because we do not want the tumor to creep up and have tumor overgrowth in 6 centimeter. But in those patients where we plan resection, we do prefer 6 centimeter or 4 centimeter uncovered stent, and then subsequently send this patient for staging. Now here you can see dark bile with echogenic material draining out. We make sure that all the contrast drains out and the to and fro movement of air happens through the deployed stent, and this completes the procedure of palliation.